We want to study together the other lecture of the pharmacovigilance, the causality and preventability assessment of individual case reports, the other lecture from Dr. Gloria Shalviri, that she is my great professor and I really love her. Okay, the objective of this lecture is to understand the necessity of case causality assessment, to learn about different criteria for case causality assessment, and to learn about how preventability assessment can be performed. We should understand the necessity of case causality assessment, to learn about different criteria for case causality assessment, and to learn about how preventability assessment can be performed. Data assessment in pharmacovigilance. How is data assessment we can do? The individual case report assessment, ICRA, or aggregated assessment. Okay, for aggregated assessment and interpretation, data assessment used for signal detection, regulatory measures, publication, interaction and risk factors, serial study, and frequency estimation. Okay, we should do the signal detection, regulatory measures, publication, interaction risk factors, serial study, frequency estimation. Spontaneous reporting is the backbone of pharmacovigilance, which is not a perfect method, but it's a backbone. Spontaneous reporting. Major drawback is the underreporting, uncertainty with regard to the causal involvement of the drug. Since pharmacovigilance particularly concerned with the detection of unknown and unexpected adverse event, previous knowledge and statistical chance is less prominent, thus the individual judgment may differ. With the detection of unknown and unexpected adverse event, previous knowledge and statistical chance is less prominent, thus the individual judgment may differ. Question concerning causality. Number 1. Can the drug cause the adverse reaction? Signal detection. If we ask, can the drug cause the adverse reaction? Actually, we want to do the signal detection. Number 2. Has the drug caused the adverse reaction? This is a case causality assessment. If we ask, has the drug caused the adverse reaction? This is a case causality assessment. If we ask, can the drug cause the adverse reaction? This is signal detection. But if we ask, has the drug caused the adverse reaction? If we ask, can the drug? This is a signal detection. But if we ask, has the drug caused in the previous, this is a case causality assessment. The answer to the first question can affect the second, but the reverse is not true. The answer to the first question can affect the second, but the reverse is not true because it's in the past timeline. Case causality assessment, drug relationship assessment, definition. A structured or standardized assessment in individual case of the likelihood of a causal association between suspected drug and the adverse event. The case causality assessment, drug relationship assessment definition is a structured or a standardized assessment in individual case of the likelihood of a causal association. A structured or standardized assessment in individual case of the likelihood of a causal association between suspected drug and the adverse event. Structure or standardized assessment in the individual case of the likelihood of a causal association between suspected drug and the adverse event. Case causality assessment system. For the case causality assessment system, we have a Cartan Lasagna, 1977, Kramer et al., Emanuele and Sachati, 1980. We have a Begod et al., 1981, differential imputation system. We have a Venulet et al., 1986. We have a probability calculation from Bayes theorem, relationship between the probability of a proposition of before and after acquisition of additional data. We have a etiological diagnostic system, Binico group, and we have a German system. These are the different systems for the case causality assessment. At 1977, we have a Koch and Lasagna. After that, Karmer. After that, Emanuele and Sachati. Then Begod. Then Venulet. Then probability calculation. Then etiological diagnostic system, Binico group, and then German system. General design of system. First question, sub question, scores the question. Then overall scores. Third, causality category, for example, possible or probable. Naranjo et al. In 1981. In the Naranjo et al., we have a decision table. In this table, we have a 10 question. We have a scoring system. We have a relatively simple. We score determine causality, and we have a 4 levels of causality. This is a Naranjo et al. We have a decision table in this system, 10 questions, a scoring system, relatively simple, and we have a scores determine causality, and we have a 4 levels of causality. Naranjo probability scales. First, are there previous conclusive reports on these reactions? Are there previous conclusive reports on this reaction? If this is yes, we should give them 1 point. If this is no, 0 point. If we don't know, this is also 0 point. Did the ADR appear after the suspected drug was administered? Did the adverse drug reaction appear after the suspected drug was administered? Okay, this is 2 point, -1 or 0. This is a point we can give it. Did the adverse drug reaction improve when the drug was discontinued or a specific antagonist was administered? Again, 1, 0, 0. Did the ADR reappear when the drug was re-administered? Did the adverse drug reaction reappear when the drug was re-administered? This is 2, -1, 0. Are there alternative causes other than the drug that could on their own have caused the reaction? -2, 2, 0. Are there alternative causes other than the drug that could on their own have caused the reaction? -1, 2, 0. This is the other question. In the Naranjo probability scales, we can ask, did the ADR reappear when a placebo was given? Did the ADR reappear when a placebo was given? The point is -1, 1, 0. Was the drug detected in the blood or other fluid in the concentration known to be toxic? 1, 0, 0. Was the ADR more severe Was the ADR more severe when the dose was increased or less severe when the dose was decreased? 100. Did the patient have a similar ADR to the same or similar drugs in any previous exposure? 100. Was the ADR confirmed by objective evidence? 100. Was the ADR confirmed by objective evidence? Now range of probability scales. In these scales, we have a score. A score more than equal 9, the category is highly probable. A score 5 to 8, the category is probable. A score of 1 to 4, the category will be possible. And a score less than equal 0, the category will be doubtful. Now we learn together the range of probability scale together. It has a decision table, 10 questions we ask. We have a scoring system. This is simple. We have a score determine causality and 4 level of causality we determine. Okay. WHO causality category. The WHO, one of the causality category is certain, event or laboratory test abnormality with plausible time relationship to drug intake. Certain means event or laboratory test abnormality with plausible time relationship to drug intake. Cannot be explained by disease or other drug. Response to withdrawal plausible pharmacologically or pathologically. Event definitive pharmacologically or phenomenologically. Re-challenge if necessary. Okay, again. Certain is an event or laboratory test abnormality with plausible time relationship to drug intake. Cannot be explained by disease or other drug. Response to withdrawal plausible pharmacologically or pathologically. The certain causality category, event definitive pharmacologically or phenomenologically. The certain is a re-challenge if necessary. In the WHO causality categories, the probable or likely is an event or laboratory test abnormality with reasonable time relationship to drug intake. The certain is plausible time relationship. The probable is a reasonable time relationship to drug intake. The probable and likely is unlikely to be attributed to disease or other drugs. Response to withdrawal clinically reasonable and re-challenge not necessary. Certain is re-challenge if necessary. Probable re-challenge is not necessary. Okay. In the WHO causality category, the possible is an event or laboratory test abnormality with a reasonable time relationship to drug intake. Could also be explained by disease or other drugs. Information on drug withdrawal lacking or unclear. The possible is an event or laboratory test abnormality with a reasonable time relationship to drug intake. The possible could also be explained by disease or other drugs. The possible information on drug withdrawal is lacking or unclear. This is possible. Unlikely WHO category causality is an event or laboratory test abnormality with a time to drug that makes a relationship improbable but not impossible. This is improbable but not impossible. Disease or other drugs provide plausible explanation. Okay, disease or other drugs provide plausible explanation. This is unlikely. The other plausible we have it, this is uncertain. The reasonable withdrawal plausible. This is certain. In the likely, this is unlikely to be attributed to disease to other drug. Response to withdrawal clinically reasonable. Response to withdrawal clinically reasonable is likely or probable, but in the unlikely, this is disease or other drugs provide plausible. WHO causality category is conditional or unclassified. Event or laboratory test abnormality. More data for proper assessment needed, or additional data under examination. Event or laboratory test abnormality, more data for proper assessment needed, or additional data under examination. This is the other causality category, conditional or unclassified, event or laboratory test abnormality, more data for proper assessment is needed because this is unclassified, or additional data are under examination. Unaccessible or unclassified is a report suggesting an adverse reaction cannot be judged because of insufficient or contradictory information. Data cannot be supplemented or verified. Data cannot be supplemented or verified. A report suggesting an adverse reaction cannot be judged because of insufficient or contradictory information. Data cannot be supplemented or verified. Okay, data cannot be supplemented or verified. What do different systems have in common? Time and sometimes location association, challenge, de-challenge or re-challenge, pharmacology, clinical, lab, exclusion or likelihood of other causes. Okay, what do different systems have in common? The time and sometimes location association, challenge, de-challenge, re-challenge, pharmacology, clinical, labs, exclusion or likelihood of other causes. Incidence figures of adverse reaction should be restricted to cases qualifying as definite or probable. Is there a sharp distinction between possible and probable? May case reports be disregarded if they qualify as less than probable? Is there a sharp distinction between possible and probable? Or may case reports be disregarded if they qualify as less than probable? Two experienced assessors showed full agreements in 35% of 106 case reports. Langtot, KL, Narendra CA, and Killing Pharmacol in 1994. This is the two experienced assessors. Causality term in European countries in 1992. One country has 7 terms, 2 countries have 6 terms, 3 countries have 4 terms, 5 countries have 5 terms, and 4 countries do not have a category certain. The European causality category is a ABO reports including good reasons and sufficient documentation to assume a causal relationship in the sense of plausible, conceivable, likely, but not necessarily highly probable. It means A. The A in the European causality categories reports including good reasons and sufficient documentation to assume a causal relationship in the sense of plausible, conceivable, likely, but not necessarily highly probable. In the B, in the European causality categories, reports containing sufficient information to accept the possibility of a causal relationship in the sense of not impossible and not unlikely, although the connection is uncertain and may even doubtful. For example, because of missing data, insufficient evidence, or the possibility of another explanation. Report containing sufficient information to accept the possibility of a causal relationship in the sense of not impossible and not unlikely, although the connection is uncertain and maybe even doubtful. For example, because of missing data, insufficient evidence, or the possibility of another explanation. Or in the European causality categories, reports where the causality is for one or another persons, not accessible, for example, because of missing conflicting data. The advantage of the ABO systems is as a step towards harmonization by European Union Pharmacovigilance Working Party. No certain or unlikely category included. Automated and meaningful way of reclassification of national reports. No need to change established national procedures and intended for the purpose of drug regulation. These are the advantages. No certain or unlikely category in the European system. We have an automated and meaningful way of reclassification of national reports. No need to change established national procedures and intended for the purpose of the drug regulation. What causality assessments can do? Decrease disagreement between assessors, classify relationship likelihood, semi-quantitative education's improvement of scientific assessments. What causality assessments cannot do? What causality assessment can do? We can do decrease disagreement between assessors. We can do classify relationship likelihood, semi-quantitative, and we can do education and improvement of scientific assessment. What causality assessment we can give accurate quantitative measurements of relationship likelihood. We cannot do accurate quantitative measurements of relationship likelihood, and we cannot distinguish valid from invalid cases. Prove the connection between drug and events. Quantify the contribution of a drug to the development of an adverse event. Change the uncertainty into certainty. What causality assessment cannot do. Major use of causality assessment are signal detection, drug regulation, scientific publications, and data exchange. In the summary, pharmacovigilance is part of governmental decision, and in making decision in this regard, facts is more acceptable than suspicion. Uncertainty in case assessment is an obstacle to legal measures, which in turn may inflict permanent damage to the commercial value of the drug. Uncertainty in case assessment is an obstacle to legal measures, which in turn may inflict permanent damage to the commercial value of the drug. We need to assess individual case reports separately before starting aggregated assessment. Case causality assessment is a necessary part of individual case assessment. We need to choose and establish criteria for case causality assessments. Establish criteria for case causality assessment. We are European, WHO, or non-EU system. We need to assess individual case reports separately before starting aggregated assessments. Thank you for time. Okay, what's this? This is a Shomok and Toronto's preventability criteria. In the Shomok and Toronto's preventability criteria, number 1, ask the question, was the drug involved inappropriate for the patient's clinical condition? Number 2, was the dose, route, or frequency of administration inappropriate for the patient's age, weight, or disease state? Number 3, if applicable, will require therapeutic drug monitoring or other necessary laboratory tests not performed. Number 4, was there a history of allergy or previous events to the drug? Number 5, was a drug interaction involved in the adverse drug event? Number 6, was a toxic serum drug concentration or laboratory monitoring test documented? Number 7, was poor compliance involved in the adverse drug events? Table 1 is a preventability criteria according to Shomok and Toronto scales. This is a definitely preventable. Number 1 to 5. Question, was a known treatment for the adverse drug reaction? Under 5 is okay. I again ask the question. Number 1, definitely of the preventable, was the history of allergy or previous reaction to the drug? Number 2, was the drug involved inappropriate for the patient's clinical condition? Number 3, was the dose, route, or frequency of administration inappropriate for the patient's age, weight, or disease states? Number 4, was a toxic serum drug concentration or laboratory monitoring test documented? Number 5, was there a known treatment for the adverse drug reaction, probability preventable? Number 5, was there a known treatment for adverse drug reaction? The second part is a probably preventable. Question number 6, was required therapeutic drug monitoring or other necessary laboratory tests not performed? Number 7, was a drug interaction involved in the ADR? Number 8, was poor compliance involved in the ADR? Number 9, were preventative measures not prescribed or administered to the patients? Were preventative measures not prescribed or administered to the patients? Was poor compliance? Was a drug interaction? Was it required therapeutic monitoring or other necessary laboratory tests not performed? These are the probably preventable. Not preventable. If all criteria not fulfilled, this is a not preventable. This is a preventability criteria according to Shomok and Toronto scale. Now we have a teamwork for fulfill of the red yellow card for adverse drug reactions, and this was a question of a 43 years old man that has a lidocaine injection and such etc. example. I have a record of this video and the other video in the pharmacovigilance playlist. Thank you for listening to me. Have a good time, and again I should thanks Dr. Gloria Shalbiri to give the lecture me and allow me to take a video. Have a good time. Bye bye.